every time I made a decision, I would run through that framework. Is this in the sole and best interest of the plan and plan participants? Is this a prudent action? Am I following my plan documents? Am I holding my plan assets in trust? And am I ensuring that I'm paying only reasonable plan expenses? And if you have this framework and you're approaching each decision with this framework in mind, you really set yourself up for success.
Welcome to Broken Benefits. I'm your host, Lee Lewis, and this is a podcast where we learn from top employer experts on how to fix our broken benefits to save lives, save dollars, and save your talent. Welcome, everyone, to Broken Benefits. I'm your host, Lee Lewis, and so excited about today's interview with Christin Deacon. Just by way of background, Chris was a director for one of the largest health plans in the country, almost 900,000 lives. While she ran this health plan as the director for 3 years, during those 3 years, she was able to help her health plan save over $3 billion. That's billion with a B. She was also a deputy attorney general and a special assistant to the governor of New Jersey. Chris has the training. She's a lawyer by training, which is a little bit rare within our space. And we're so excited to be able to have her today to share some of the critical items that she was able to do in order to get this great success. And with that, Chris, so excited to have you on the show. Welcome today.
Thanks for having me, Lee. I'm excited to be here.
Yeah, no, absolutely. My pleasure. So jumping right in, one of the things that is, I think, critical to solving a problem is finding the best way to understand it. And I find that there is, even for people who are very focused on solving the problems, there's a ton of variability in how people understand the problem that they're trying to solve. And I was wondering if you could maybe walk us through how you deconstructed and approached the challenges in healthcare.
Sure, great question, and it's usually where I start. As you could see from my background, I didn't really grow up in healthcare. I didn't grow up in the HR space or the benefit space. I was a corporate restructuring attorney and found myself in healthcare several years ago, running, like you said, one of the largest health plans in the country with 820,000 lives. And I very quickly realized that I needed to, I couldn't know all of the things. I couldn't know every in and out of, what every acronym is, what every quality metric was, what every institute, and peer-reviewed journal article I should read. But what I could do to make smarter purchasing decisions and decisions for the health plan was come up with a framework for approaching decision making. And I kept, the Department of Labor handbook sort of on my desk as a fiduciary guide in guiding my decisions. And so I really, built this fiduciary framework with which I approached every decision that I made. Just could recite, every time I made a decision, I would run through that framework. Is this in the sole and best interest of the plan and plan participants? Is this a prudent action? Am I following my plan documents? Am I holding my plan assets in trust? And am I ensuring that I'm paying only reasonable plan expenses? And if you have this framework and you're approaching each decision with this framework in mind, you really set yourself up for success in all that you do as a health plan administrator.
That's awesome. So here's another thing too. A lot of people who run benefits are fiduciaries over the funds. And as you just mentioned, we need to be prudent. We need to make sure the funds are used for their value or for their benefit. What do you think are some of the common misconceptions we have about being fiduciaries? What are some of the common blunders we might, be committing to kind of not be great fiduciaries that maybe we don't even realize?
Right. I think probably the most common is not understanding who is and who is not a fiduciary. And with that, comes a mistaken assumption that you've outsourced that legal liability when you hire perhaps a health benefits consultant or broker or a third-party administrator, or even if you're fully insured, your carrier. But if you sponsor an employer-sponsored health plan, there has to be someone within your organization that retains fiduciary liability, whether that's the CFO, the CEO, or a fiduciary listed in a plan document. And while you might, um, sort of have some functions that, let's say your third party administrator exercises discretion over and therefore could have some fiduciary liability, that doesn't abrogate you of really being responsible for managing how that duty is carried out by a third party. So I think that's the biggest misconception, is thinking that, if somebody else is performing a set of discretionary duties, you're sort of off the hook, which is just not the case. Even if you get someone to accept contractual fiduciary liability, whether that be your carrier, PBM, or consultant, or some other third party, it's still on you as a fiduciary to oversee how their duties are undertaken. So it's a liability that you can't really escape. But I also think it's an opportunity, because with that fiduciary responsibility, you can throw your weight around a little bit, because of sort of the importance of the duties that you have to undertake. And so if you have
Mm.
a carrier or a third party that challenges your, for example, your right to data, or your
Mm.
right to transparency, or to demand information on the prices that your health plan is paying, you can absolutely fire back that I am a fiduciary. My legal, my personal liability is, on the line here, and I demand that information. Just as an example, as of the power that being a fiduciary carries with it.
Wow. Now, I almost hate to ask, what are the penalties for failing in that duty?
So, a breach of a fiduciary liability can carry with it, again, personal liability, and civil penalties for, either restoring the plan, returning profit. It depends on how the fiduciary duty was breached, right? If you're not overseeing the plan, and as a result, overpayments are made, or if you, engage in some sort of self dealing, or allow a vendor with a conflict of interest to act in a capacity that negatively impacts your plan, you're going to have a personal liability to make that plan whole. And I think this is really interesting. And certainly when I talk to the C-suite, this is where the ears really perk up, even if their eyes are glazed
Wow.
over and the rest of the talk. But D&O policies, right? They've
Okay.
gotten the price of D&O policies over the last several years, with really the explosion of 401k litigation and class actions based on unreasonable fees and failure to disclose and conflicts of interests in the 401k space, have caused fiduciary liability premiums, or coverage for fiduciary liability, to either become unreasonably expensive, or they just get carved out altogether. Or in some cases, what used to be essentially like a $0 deductible for that type of liability, I've seen in some cases it's now up to 10 or $15 million before the coverage even
Oh,
starts kicking in. So I think that we tend to think of the benefit space as very risk averse. And I think that that's fine. But I hope that what people are starting to understand, and professionals in the space are starting to understand, is that the real risk, the real legal risk and fiduciary risk, lies in not doing anything. The risk
wow.
shouldn't be doing something
Hmm.
new and different going forward. The risk should be seen as status quo, and sort of allowing health plan, and costs to continue to rise the way they are.
Wow. Now, I'm like that CEO. My ears are kind of perked up here. Let's just say for a second that I'm terrified, and I want to do something to help insulate myself against all this risk. What do I do? What are the first steps that I take? Especially when you say vendors who have a who have a conflict of interest. Like, I, from everything I can tell, we swim in an ocean of vendors with a conflict of interest. So how in the world in this ocean I'm swimming in, what's my life jacket?
Yeah, well, I mean, I think that's the first step, right? And like in anything in life is you have to acknowledge that you have a problem, Lee, right? You have to pull your head out of the sand.
Step one.
Step
Okay.
one, pull your head out of the sand and recognize that yes, it is a tremendous undertaking, but it's not one that should be scary. It's one, again, full of both obligation and opportunity. So I've put together a number of checklists, and I think there are a lot of things that are consistent across those checklists. And first, have you identified who are your planned fiduciaries in writing? Right. So you're asking, like, what can you do to protect yourself? And I think that I sort of listed those 5 principles off, and they seem sort of philosophical, but what do they mean in practice? Have you identified all of your planned fiduciaries in writing? Have you asked your vendors to either agree to or not, whether or not they hold a fiduciary obligation underneath, under their contract? And create a list of policies and procedures with respect to evaluation of conflict of interest. Disclose, for example, if you are a carrier and you're my carrier, please disclose if you have an ownership interest in any of the providers that you're paying on my behalf. I think what we've seen, and I use this example because I think it's really pertinent. Um, you know, Carriers are purchasing providers, and the provider, I think Optum acquired like 10,000 physicians last year, if I'm remembering the
Wow.
stat correctly. In many of these cases, the carrier that you are paying to negotiate rates and pay claims on your behalf also owns the provider that they're paying, right? So if you think about the potential for conflict here, if you own the entity that you are responsible for negotiating with on behalf of your employers, where's your incentive to negotiate a lower price, right? Um, so I don't know that we can necessarily, as
Wow.
HR officers, solve this dynamic that now exists in the market. Like, am I as an employer able to sort of disaggregate this and preclude all conflicts of interest? Probably not. But what I am able to do is get full visibility into the conflicts so that I can protect myself against it. Disclosure of conflicts of interest, transparency, sunshine is the best disinfectant. I think it gets you part of the way there. So a lot of written policies and procedures. You must have access to all of your healthcare claims data, and your
Okay.
pharmacy data. Absolutely, bottom line. And there are several other things, sort of like tangible things. I think the C-suite can do and CHROs can do, to
Mm.
take those principles and actually apply them in a really tangible way.
This is great. Are there a couple others that just come off
Sure.
the top of the head real quick?
Yeah, I didn't wanna, like, bore you with just a rattling of lists, but,
Well, yeah, a couple other items, just lightning round me real quick, and then
yeah,
we'll go to
yeah.
the next topic.
So, when you're talking about, the prudence of your healthcare decisions, so you need a framework for evaluating the prudent purchasing. So another great
Okay.
example, and I could tell a personal anecdote. When I first started working for the state, and one of my first projects was running a TPA RFP. We had a large budget
Mhm.
hole to fill. This is PBM and TPA reprocurement was part of the way we got there. And I was told that one of the ways, or the primary way, we evaluated our TPA partner was through a discount analysis. And I told
Okay.
our consultant, well, a discount off of what? Like, a discount, like, how do I know the price?
Yeah.
Because I would, remember, I was somewhat new to this. And they said, oh, no,
Sure.
no, we don't know the price. We just know the discount. And, I was just like mind blown that we could be spending as a state $5 billion, and that's with a B, on healthcare claims through a system with which we had no insight to the price and no contractual guarantees over the price. So after much convincing, we changed the model to do a unit cost analysis with a unit cost guarantee year over year to ensure that our unit costs weren't going up.
That's
Um,
amazing.
yeah, and then I guess, the last was not last, there are more, but another significant one was the procurement of our PBM partner, pharmacy benefit manager. Um, we were never really, we weren't improving as much as we knew we could financially in our standard bidding process. And so, again, this is sort of the application of that prudent purchasing standard or
Right.
reasonableness of plan expenses. We engaged in a creative procurement methodology called a reverse auction, which really unleashes market forces against the big PBMs for us because they were the ones that could handle the business, the size of the business, and they bid on
Right.
each other, and we were able to unmask pricing so that they could go around another round and really, lower prices again to get more aggressive to win the state's business. And we went 3 rounds, ultimately saving over $2 billion over the course of that 5-year
Wow.
contract term. So
Wow.
you can really effectuate major change with putting some of these principles into practice.
Wow. That's incredible. So now I'm thinking, okay, you came into this program. You're now the new director. You're learning about all these, conflicts of interest, the vendors, and everything that you need to purchase. What was what was the biggest goal that you had during that period? What was it that you wanted to, achieve as you were embarking on this?
Um, so I took my responsibility to be a good steward, and I use that term not lightly. Steward of
Mhm.
taxpayer dollars. And so for me, that was taxpayer money because I'm a resident of the state of New Jersey. My children attend the schools. I know the tax burden that
Mm,
working, New Jersey residents felt, and so it wasn't necessarily just about cost reduction, but it was how do we improve um, the benefits we were offering? Because it didn't take a lot to sort of peel back the layers of the onion to recognize that we were paying an incredible amount for really low value care in some settings. If you looked at our C-section rate, for example, at one particular hospital, our elective C-section rate was close to 50%.
wow.
How on earth were we paying a premium,
Wow.
to this hospital for making our moms and babies undergo unnecessary C-sections? And so I think it was again being a good steward of taxpayer dollars, but that didn't necessarily mean having a sole laser focused on cost. It meant having a laser focus on cost and quality, i.e., value. Are we getting the value? Are we getting what we're paying for our healthcare dollar? And I think that most benefits leaders struggle with this. When you're looking at hospital prices, I think RAND 4.0 just came out not too long ago, as did updated Leapfrog scores. We're paying an
Mm,
incredible amount, multiples of CMS, for care that is either not the highest on the quality spectrum or incrementally not better than hospitals that are charging half of what some are. So the variability in cost and quality was a big problem because when you have that kind of variability, you're not spending the taxpayer dollars prudently.
yeah. No, that makes perfect sense. So now you've discovered that there's this high variability. What can you do to start controlling for that? Do we go to our insurance carrier? Do we change our plan design? Do we buy a new app? Like, what do we do to start tackling that?
I don't think you buy a new app. As much as I would hope that technology and as much as, private equity and venture capital is out there looking for the technological silver bullet, it doesn't exist. I'm going to let you in on a little secret. I do think that technology will play a role in the solutions, and again, it's not the solution. It's we have a structural problem, and so therefore
Right.
we need a structural solution that's going to require a lot of rebuilding,
Mm,
a lot of really hard discussions and conversations, And when we're talking about how much we're spending on healthcare, $4 trillion, almost 20% of GDP, there will be some pain,
Mm,
right? Like there will be some pain, not from a patient perspective, but perhaps the best use of our public healthcare dollars is not in creating another glass atrium in the middle of a city, with private five-star hotel rooms for every hospital admission. Like at some point, we have to take a look at what we've built and decide how we're going to I say blow this, insert explicative here up and rebuild what we would want to see. So going back to your question, because I kind of digressed, but what can we do to start addressing variability in cost and quality?
yeah.
I think absolutely we have to hit hard and hit fast on hospital prices. Hospitals, and I'm
Okay.
not talking about your rural struggling hospitals that absolutely need either support or they need some sort of structural fix, but I'm
Right.
talking about I'm presently sitting in an office in Manhattan surrounded by some of the most egregious billing and prices in
Mm,
the country. um, it's unsustainable, it's unjustifiable, and we need political leaders to grow a backbone and figure out a solution to high hospital prices. And when I say regulators, I don't necessarily mean like rate regulation. I mean, stop giving them a free pass on their nonprofit status. Stop giving them a free pass on their capital expansion projects that are costing taxpayers and commercial payers,
mm,
hundreds of millions of dollars a year. And so that's, it's short term, but
yeah.
long term. I think more from a structural perspective, what we can do as employers is incentivize high value care. What does that mean?
Mhm.
Incentivize utilization at high value primary care settings. So whether that's direct primary care, advanced primary care, and it's interesting that I see a future of healthcare where the primary care relationship is restored, and we talk about it in a future state, when in fact it's actually a hearkening back to the true roots of medicine, right? It's
Mhm.
relational, it's personal, it's local, but in
Mm,
this relationship, you now have a trusted and aligned, financially aligned partner to control the downstream costs of medical care, right? So if my
right.
primary care physician is recommending that I go for testing, a certain testing procedure or an evaluation for a surgical procedure, I'm going to trust where they tell me to go, and I'm going to incentivize
Right.
that primary care physician has both a financial incentive and a relational incentive to send you to a high value provider, the surgeon that does 500 knees a year, not five, right? So
Yeah.
and I think that's all about, again, realignment of the financial incentives across the employer, the member, and the provider, um, to, again, whether it's through plan design, incentives, to utilize high value care. And through that, I think we'll start to build structural change into the system.
Yeah. What do you think is like the biggest belief we have as employers that we get wrong?
Oh, there's so many, Lee.
Oh no.
Yeah, no, it's okay. I mean, I think that I'll go back to another anecdote and story that I learned early on, and that was, again, in this TPA RFP process. One of the other means
Yeah.
by which my consultant told us that we were scoring or evaluating potential partners was through what's called a disruption analysis. And a disruption analysis is essentially how many of my members with this carrier versus that carrier versus that carrier are going to have to find another network provider because, the disruption between in and out of network.
Mhm.
And, if there was a bigger disruption, that was a worse score. And if there was disruption over 30%, they were disqualified. And I understood where they were coming from, but then I asked and honestly asked, well, where's the quality component here? Because if
Right.
that network that, let's say was going to disrupt 30% of my members and their providers, if those 30% were actually really bad providers from a quality perspective, I'm not actually that upset. Yeah, well, I have to answer the phone a little bit more and there will be some
Right.
noise, absolutely. But where's the quality component to this? And the response was looked at me like I had two heads. And so
Wow.
this is the I think the biggest miss that we've had over the last 10, 20 years is that like bigger is better. More access at, sort of
Mm,
all costs. I want the broadest, baddest, biggest PPO you can give me. I want my members to be able to go to any doctor they want without any insurance company, prior auth, utilization management, steerage, nothing in between.
mm,
And while I
mm.
know where that sentiment has come from, I don't think that it's served us well because now we have members that are accustomed to not having a primary care provider because they don't need one. They just either go to urgent care or they go to their specialist as they see fit. And
Right.
as healthcare consolidation, both vertical and horizontal, has increased, there's increasingly sort of one monolithic entity in a market or a few that are sort of providing, they're the imaging center, they're the urgent care, they might
Right.
even be the primary care, and they certainly are the specialist in the hospitals, and they're just, it's throughput. So
Wow.
I think I hope that both employers and employees, probably more importantly, are going to have a willingness to meet us halfway, to understand that now that we have the cost and quality data in our hands, we have a duty to do something with it. And it
Yeah.
is incumbent upon us to make sure that the places to go to provide high quality, high value care. And in
Mm,
exchange, I'm going to, ensure that we control your costs and we're not going to engage in cost shifting anymore so that you can no longer access care. I'm going to keep your healthcare affordable, but meet me halfway so that I can get you to the best doctors. And I hope that that is in our future.
no, I sure do as well. You mentioned harkening back and bringing primary care in. What can we do as employers to make primary care more centric, and hopefully to bring a resurgence of it?
What can we I mean, I think this is one of those areas where we have to have a very realistic understanding of the current marketplace, in the absence of employer-driven primary care relationships, and that is the continued purchase of the large systems of primary care physicians. The number of independent primary care physicians office is rapidly shrinking, and COVID has only accelerated that.
Mm,
So understanding that again, the high value care that is provided in a primary care setting, um, I think is number one. You have to understand that value and understanding that 80% of behavioral health care, I think, prescriptions come out of a primary care physician's office. I mean,
mm.
um, your primary care physician has two incredibly powerful cost sort of levers in their hands, and that is their referral pad and their prescription pad, right? So if we're just talking about cost.
Wow.
And then if you look at, your members' holistic health and well-being, really that's going to be foundational in your primary care. So recognizing number one, the value, and then what do they do with that knowledge? In my opinion, knowing that the independent physicians that are largely going away and understanding the dynamic of non-independent physicians that are associated with large health systems, I'm pushing employers to move to a direct contracting model with advanced um, uh,
Mhm.
primary care providers, with direct primary care providers that have been tech enabled, that are going back to that realignment, when the provider now is no longer sort of a vehicle to drive volume to a hospital system, but rather a vehicle to provide high quality care to my members, and whether that's at an on-site clinic or
Mm,
near site or even virtual in some cases, if you're in a rural setting, a virtual first model. I think that we begin to get there. And then you can also pull the levers on the bigger cost downstream, the downstream costs, again, through those referral patterns, chronic care condition management, and
mm.
then certainly the prescription pad.
Wow. This reminds me of a statistic. I saw this last week that like in the early 1990s, referral rates to specialists were about 5 or 6%. And today they're around 40%.
Right.
And, but, hospital admission rates and curing rates and things like that have kind of remained the same.
Well,
It's,
I'll hit you with another
uh,
statistic, and it
uh,
was that hospital-affiliated primary care physicians are associated on average, I think it's like 500,000 in revenue to the hospitals per primary care physician. So they're
oh,
essentially, they're the funnel, right? If somebody needs a referral to go to a hospital or a specialist,
mm,
they want you to see the hospital associated primary care physician who can
mm,
then, yes, you go to our hospital MRI that is going to cost $3,000 versus the freestanding that would cost you 300. Or you
mm.
go to our emergency room or our neonatology or what have you.
Wow.
Um, and at the end of the day, yeah, it's a business, and we have to recognize that as human resource officers and those responsible and entrusted. Going back to this fiduciary principle, right? Our members don't have this information. They don't get to contract with primary care physicians. They don't get to contract with carriers, hospitals, and other third-party providers. They've entrusted, i.e., fiduciary, they have entrusted us with those decisions. So it's really
Right.
important that we make the most of that trust.
How do we keep them from resenting us or feeling like we're trying to push them in a way that just is trying to save a buck?
Yeah, I mean, I think you have to lead with quality, and I don't think that that's just disingenuous, because
Okay.
this is one of those areas, healthcare is one of those areas where if you are spending less, you are likely doing a better job taking care of the health and well-being of your members. But listen, it's an uphill battle because you are fighting a narrative out there. And I've got to say that largely it's self-inflicted harm, because we did the cost shifting high deductible health plan experiment, and one I think like one third of employees are on some sort of high deductible health plan. And I think that the data is coming back that when you only have $400 in your savings account on average, and that might have gone down now that a gallon of milk is, $6.50 at the grocery store.
Right.
You don't have $400 to hit your $4,000 out of pocket deductible before your insurance even kicks in. So you either avoid care or you
Mm,
wait, and then you're seeking it at a high cost, low value setting. So I think a lot of this is largely self-inflicted. We've
mm,
engaged in some experiments over the last couple decades that we've learned from. And trust is something I think we need to earn back from our employee populations through
mm,
flawless execution, through honesty and integrity in what we've tried and what didn't work, and being very honest about that. And through partnerships. This is one of those areas where I think it makes for strange bedfellows, right? Like, I
mm.
was special assistant counsel to Governor Christie's office, and by the time I left the health plan, I would say, in any public setting, that my strongest advocates and indeed friends and allies were our public sector labor unions. At the
Wow.
end of the day, um,
Wow.
because at the end of the day, the right, left, or indifferent, you want to engage in fiscal responsibility, but you want what's right for your members. And that means not having unnecessary spine surgeries. That means getting your cops to the highest, rated musculoskeletal folks to do a knee replacement. Um,
Right.
so we are aligned if we can get past that initial narrative and really align ourselves
Mm.
up against what is the sort of, I'm not going to say enemy, but potential foe here in truly disruptive change, and that is the status quo. That is hospitals that are going to ride the fee for service train until they can no longer ride
Mhm.
it. Um,
Yep.
and carriers and insurance companies that want to make as much of their 15% MLR as possible. Um,
Right.
and so, yeah, I think that we have a lot of work to do in the trust department, but it's an undertaking that's worth doing.
I want to pull the thread a little on what you just said a moment ago on MLRs. Most people believe, hey, insurance companies want costs to go down, right? Because they bring in premiums from people who buy like an insurance policy, and then they pay those premiums back out as claims, and they want those claims to be low. I know, for instance, with car insurance, I know that Geico doesn't want to pay like a ton of money to fix my car, right? And so why doesn't that translate over to health insurance?
I think there are a few reasons. I mean, first, you just called it out, and that's the medical loss ratio, which is just another way of saying for every one healthcare dollar, an insurance company has to pay 85 cents of that dollar on actual clinical medical costs, and they get 15 cents of that dollar for other things like profit, right? And so
Right.
if that's the sort of the math, and they want to increase profit for shareholders or otherwise, then the dollar, the denominator has to get bigger, right? So
Hmm.
the idea that there is an incentive by insurance carriers to lower costs, and lower prices is just, is a fundamental misunderstanding. And I think that I'm hopeful that benefits leaders are wise to this. But you asked earlier, what is probably one of the most harmful, misunderstandings? And I think for the American people, this is probably one of the bigger ones. I have
Mm.
spoken to elected leaders and cabinet level officials at the state and federal level, or deputy cabinet that don't understand, or at least didn't
Yeah.
understand, that carriers and hospitals don't sit on opposite sides of the table and duke it out on your behalf. Absolutely no. That is not the case. They sit on the same side of
Wow.
the table and decide how to divvy up healthcare dollars between them. um, and how to, I'm not going to say how to necessarily inflate costs. Well, no, I will. I'll say that. How to make more money. And if that means that the overall pie has to increase, then that's how it's going to be. I mean,
Oh,
I just
does
heard
it
a
mathematically?
CEO of a hospital in Wisconsin talking, and this was in a public setting. And he said, we talk a lot about lowering the total cost of healthcare. There was a question from the audience, and he said, we talk about it a lot, but it's not happening. Total cost of care, total healthcare costs, prices, they're not going down. Um, and there's nobody challenging that on the other side. If your carrier isn't challenging that for you, you can, as an employer, by engaging in direct contracting. Then you can pull the strings. But yeah, I mean, I think that it's a huge misunderstanding that
Wow.
needs to be corrected sort of in the general domain. Because the kabuki theater out there of, the anthems of the world having, duking it out with a hospital system over whether or not they're going to be in or out of network next year. It's really a way to get the members in that region behind the fact that they're going to have to pay more for healthcare next year, because they scare them into thinking you're
Mm.
going to be out of network. You're not going to get access to your OBGYN and have a hospital where you always, or I'm sorry, have a baby where you always thought you were going to at the hospital you had your last. And then, when the carriers come back and say, well, if you want access to New York Presbyterian, you know that they charge 400% of CMS, and you're going to have to live with those increased premium costs. And so it's a way of sort of galvanizing and stealing consumers off to like having to live with price increases. And
Mm.
and it's yeah, it's unfortunate, but it is absolutely something we need to deal with as an industry.
What was the biggest risk that you took while you were trying to make this happen? Because I mean, everybody you were going against were pretty powerful, entrenched intermediaries.
I would say I'll give you two risks, one that panned out and one that didn't. Um,
Please.
so I think the biggest risk was that first RFP, and when I say RFP, it's really a contract because our RFPs essentially become the contract with our the way that we do public procurement in New Jersey, was with the TPA RFP because there were some really what I now understand to be revolutionary provisions in that contract that it was a risk because we didn't know that anybody was
Wow.
going to bid. No cross plan offset.
Oh.
Yeah, like no cross plan offsetting, um, disclosure, certain disclosures and transparency requirements, um, unit cost guarantees, so no more discount analysis, and you actually had to disclose prices within a geographic region, and then we held you to those prices year over year. So it was really a unique RFP with some, what was a lowest. We also had a lowest. Um, Lower, we could only play the lower of negotiated rate or build rate. And so if a hospital billed, and I actually saw this, like $600,000, but the agreed upon rate was 2 million, and this happens, we were only ever contractually required to pay the 600,000. Because there are instances where they might have agreed to a DRG rate for another,
Mhm.
at another rate. So some pretty remarkable contract provisions, and we did get bidders, and it was competitive. Um,
Mm.
but the segue from that is the other risk is then taking unpopular positions and uncomfortable positions and holding vendors to account, holding vendors to that contract, and performance and financial guarantees. um, you become a really unpopular person when you point out all the things that
Mm.
have room for improvement. So I would say the riskiest thing for me, and you know what, I'm not going to say it didn't pan out. It just panned out differently than I had hoped.
Yeah.
But taking on organizations, very large organizations that have been long-term and vendors for 20, 30 plus years with public
Mm.
sector entities is a very challenging, and you win some and you lose some.
Yeah. No, that's a great piece of advice. And the items that you added in there are super helpful as well. What
Yeah, and happy
how
to
do you
always
get
share with you any of those contract provisions. They're public information because it's from a public sector entity. So
Hey, no, that's great. I'm excited about making that available as well. What how do you bring stakeholders together to get behind this? Because I imagine you felt pretty lonely sometimes.
you know,
Or not
I think,
lonely, but you felt sort of like, you're marching a hard path, right?
yeah, I think so. But the remember that those principles that I chose to live by, and when I say live by,
Mhm.
work by, very early on, they were always in sort of a guiding force, right? I didn't have
Right.
to engage in, there was a lot of soul searching in many, many decisions, especially when COVID hit and it's balancing cost and access and what do we do in the situation that nobody's ever dealt with. But those
Mm.
principles, if you let them sort of be your North Star, you never
Mhm.
stray too far from making the right decision, or at least a decision that is very defensible and can always be supported by data and good principles. Um, so And the other thing I'll say is, despite some alienation by particular groups that may have been disrupted by some of these decisions,
Yeah.
I always had the support of our labor partners who, at the end of the day, knew the importance of controlling costs to maintain the sustainability of their benefits, and
Mm,
always wanted to do right by their members from a quality perspective.
that's great. How how do we design benefits that people love?
Oh, easy. I'll tell you that. How do we design benefits? So I think you have to, and this is an exercise and a practice, not a sort of check the box. Um, it's a customized approach for each population. So Boeing is not the same as Walmart, is not the same as the 32BJ Health Fund, is not the same as New York or New Jersey firefighters.
Right.
Um, but recognizing that at the end of the day, these are this is your mom, this is your dad, this is your child. Bringing back the human element of what are we doing here? Yes, we're providing a benefit, and there's a lot of sort of operational and administrative and financial pieces that go into it. But I think circling back to that trust that's been sort of handed over to an immense amount of trust has been handed over to you as an employer sponsored health plan to provide benefits that, quite literally, when people have been handed a life and death diagnosis, they don't
Wow.
want to have to worry about who's in and out of network
No.
and where am I going to be able to get the best doctor, am I going to be able to afford my medication.
Right.
So, I think all the things that we've talked about, the fiduciary approach, et cetera, but at the end of the day, the human element is so important. Put yourself in the shoe if you had a child who had substance use disorder and needed help immediately. What would you want?
Mm,
What would you want your experience to be, or not?
mm,
And it's probably not remembering, first and foremost, I have to call my insurance company to get a prior authorization. Um, it's where do I go
right.
for help? So,
Where do I go? Who do I
turning the human
call?
element.
I love that. What a terrific way to finish. This has been wonderful. Thank you for joining us today and for sharing all of this. If someone wanted to reach out to you to learn more, to get your advice on something,
Mhm.
what would be the best way to do so?
So I'm very active on LinkedIn,
Okay.
Chris Deacon. And then I also, you can email me at cdeacon at
Yeah,
versanconsulting.com. That's
okay.
VERSAN consulting.com.
That's marvelous. Well, thank you for sharing that, and that will be included also in the show notes for all of those listening. Thanks to the audience for listening in here, and please send the link to this episode to any friends who might be able to benefit from the great advice that we've just been able to hear today. And thank you for listening in to Broken Benefits. Take care. Thanks for joining us on Broken Benefits. If you enjoyed today's episode, please subscribe to our YouTube channel or on your favorite podcasting platform. Also, please share today's show with a friend or colleague. It's free to do, and it helps us spread the message to as many people as possible. Until next time.